Go again and begin.
Yeah, hello everybody. I'm Dr. Georg Northoff. I'm a psychiatrist and neuroscientist at the University of Ottawa in Canada. And I want to talk to you about a clinical phenomenon which is rare but very dramatic and can be healed very well. Catatonia. What is catatonia? Catatonia is a psychomotor syndrome. You will see patients who can't move. They don't speak. They show mutism. They not only don't move, but they also show often bizarre postures, as for instance here in the picture. And on the right, you will see different typical motor symptoms. Immobility. They don't move. They show abnormal muscle tones, flexibilitas cerea. And they show posturing. And here already comes one very important differential diagnosis. When you see such a patient, you would think that could also be a Parkinson's patient who can't react to the medication anymore, or a new Parkinson syndrome patient. You don't know. But there are certain differences. Typically, the Parkinson patient often also show akinesia, meaning they do not move. However, they do not show the kind of posturing of their arms or sometimes even of their leg as catatonic patients do. And surprisingly, they show this posturing against the gravity, meaning they hold the arm up for hours, in former times, even for days or weeks, without apparently getting tired. So this is already one key differential diagnostic syndrome. Then in Parkinson, you know that they typically also show this tremor, and which is not the case, usually often not the case in catatonia. And often the catatonic patient also show very intense anxiety. Yeah, they cannot control their anxiety, which you can have in Parkinson patients, but usually it's not the case. So the typical trias of different symptoms in catatonia is behavior, abnormal posturing. Then you can also have hyperkinesias like mitgehen, mitmachen. They follow you all the way. They copy the same kind of behavior you do, motor imitation. Motor symptoms, as already mentioned, hypokinesia, hyperkinesia, and strong affective symptoms. That is very important for the differential diagnosis of, for instance, catatonia versus Parkinson's or other neurological disorder. And also not to forget, catatonia does not only occur in psychiatric disorders like schizophrenia, depression, or other anxiety disorders. They can also occur in a variety of medical disorders. I've seen, as a psychiatrist, as a consultation liaison psychiatrist, many catatonic patients, also in medical emergency setting or in surgical clinics. So very important to consider, catatonia is a syndrome which can be associated with different kinds of disorders, mainly psychiatric, but also medical. How can we assess catatonia? One way is there are different catatonia scales. There's one scale, the Bush-Francis rating scale, but it only considers motor and behavioral system symptoms. We ourselves developed a catatonia rating scale, which includes motor items, affective items, as well as behavioral abnormalities. So this is very important. So it gives you a rating. You can objectify the diagnosis. And we have also, more for the post-acute catatonic state, developed a scale for the subjective experience of catatonia. I will come back to that later. Now, you probably want to know a little bit about the neurobiological basis of catatonia. And it includes the typical, some of the motor cortex, of course, because you have motor regions abnormalities. You can see here in the green and the purple, the motor cortex, supplementary motor cortex. However, you also see a lot of other cortical regions, for instance, the orbitofrontal cortex here in the front, you see the prefrontal cortex, and you see also the parietal cortex here, particularly in the brain on the right. So the question is, what is the origin of these symptoms? Where do they come from? Are they primarily motor or psychomotor? There are two alternative models for catatonia in the current literature. You have a typical motor model where you can see this here. It goes on the left, it goes through the dopamine, then to the basal ganglia, the thalamus, and then the sensory-motor network regions like the motor cortex. However, the affective abnormalities and the slight discrepancy in the motor and behavioral symptoms between catatonia and Parkinson suggests that maybe the origin of catatonia is not primarily motor regions, but psychomotor, meaning other cortical regions, which in turn downmodulate the motor cortex. And that is here on the right. I sketched this that other cortical regions or also other subcortical regions like serotonergic regions, serotonergic transmitters from the rougher nucleus subcortically may modulate the motor system. That leads me to different kinds of circuits and how, for instance, these different kinds of motor symptoms can be psychomotor symptoms in catatonia can be explained. Here I show, for instance, the hypokinesia or psychomotor retardation, and you can see here, you see the white and the blue is the typical motor circuit from the dopamine substantia nigra over basal ganglia and thalamus to the sensory-motor network. Then that can be abnormally modulated by, for instance, the rougher nucleus and serotonergic substances. And you see, I don't explain the details here, you see that different impacts can lead to opposite changes in the motor cortex. Why is that important? Because these are the dopaminergic pathways are abnormally modulated by serotonergic pathway, and they in turn modulate GABAergic pathway. And that's very important because we have a GABAergic substance like lorazepam, which can dramatically affect the catatonic state and reverse it within 5 minutes. So these circuits are important because we have a very immediate and rapid therapy in place, meaning GABAergic agents like benzodiazepine, which can have a dramatic effect on catatonia. This is why also the differential diagnosis to catatonia versus other neurological movement disorders is very important. Here you have another mechanism that abnormal balance between different cortical regions. Here, the sensory-motor network versus the DMN, the default mode network. And that has been shown to be related to different symptoms in catatonia. You can also say there's a cortical imbalance. Why is that important? We can see that different cortical or subcortical mechanism can all lead to catatonia. And that is exactly what we also observe in the clinical realm, that different disorders which involve different cortical or subcortical regions all lead to catatonia. So catatonia is more sort of a final common functional pathway, a syndrome, just like fever is a syndrome and a result from different states, medical states, which all result in fever. And one probably has to imagine catatonia in the same way, meaning catatonia can occur in various conditions, both psychiatric and medical, as I mentioned earlier. Then we have yet another mechanism where the global brain activity is abnormal. You see this here in these brains, the red and the blue. And that in turn gives abnormally decreased or abnormally high activity to the sensory-motor network. For instance, compared to climate. Unfortunate topic, but the ozone layer is too thin, and that is all over the whole globe manifest, but affects the different regions in different way. Same here. If the global brain activity is abnormal, it may affect the sensory-motor network in an abnormally strong or abnormally weak way, and that can lead to psychomotor changes. The next question, why are these different symptoms coupled with each other? There's a certain logic to their coupling, that you have motor, behavior, and affective coupling. So there seems to be an intrinsic wiring by the brain, within the brain, and that is because of its intrinsic topography. So this means catatonia is a unique example of a brain-mind disorder. It's not just neurologically, it's not just psychiatrically, it's right at the border. It's a typical brain-mind disorder, and that is to be considered. Meaning there's a strong subjective experience and meaning of the symptoms. And on the other hand, you have an objective manifestation, like in the motor symptoms. And that is something, as a clinician, you always want to consider both the symptoms as well as the subjective experience of the symptoms. And for that reason, we developed also an experience for the subjective experience of the symptoms. Actually, how did we come about this? We earlier on compared the experience of the akinesia, the motor symptoms in Parkinson, with the experience of the symptoms in catatonia. We asked the patients, how do they experience their symptoms? And that really led us a completely different experience. Parkinson's experience, their motor symptoms, they're blocked, they cannot walk, they cannot move, and they cannot properly target specific things because of their tremor and their akinesia. Catatonia patients will not tell you almost anything about their motor symptoms despite this dramatic posturing, because they often remain unaware of them. But they're very much aware of their affective symptoms, their emotional symptoms. They often cannot control their emotions. One extreme example is one of my patients. She came 4 times in a full-blown catatonic state, each time after she got married. Because the marriage involved so much emotion, she could not control her emotions, and she became catatonic. Very tragic. Often catatonic syndromes obviously occur if you are in extreme states of anxiety, like if you suffer from delusions, hallucinations, and schizophrenia, or also from at least ruminating thoughts, suicidal thoughts, like in depression. And as a consequence of that, you become completely paralyzed, cannot move, and that's the final straw. So this subjective experience is key in catatonic patients. And that's very important to consider. Why? Because as I indicated, we have one of the few, if not the only example of a mental disorder, and also of an organic catatonia or medical catatonia, where we can provide immediate therapy in 60% to 60-80% of all cases, meaning by giving either oral or intravenous benzodiazepine, ideally a fast-acting like midazolam, or even better, lorazepam. If the lorazepam oral doesn't work, try right away intravenous. Often you have better effects of intravenous lorazepam than oral lorazepam. If in 20% of your cases the lorazepam or other benzodiazepine doesn't work, try some glutamatergic agent like amantadine or ketamine. And if that doesn't work, the catatonia becomes more severe, you can also try electroconvulsive therapy. That sounds brutal, but can be extremely helpful. Most important, there's also what you call febrile catatonia. There the patients present with the typical catatonic symptoms as described, motor, behavioral, affective. And in addition, they have also various somatic vegetative abnormalities like fever. And this is important to consider because this fever can be life-threatening. This form of catatonia has early been called lethal catatonia. So here you really need to be on your guard and try to immediately therapy that, and ideally you provide right away electroconvulsive therapy. Do not hesitate. Do not spend days on trying other medications doses. If your patient is in a serious febrile catatonic state, do right away electroconvulsive therapy. You might need 20 to 40 sessions. Please be patient. I had several young people with severe catatonia, febrile catatonia. You need to be patient, and please, for the sake of the patient, try to right away electroconvulsive therapy. If not available in your clinic or in your outpatient center, please contact the proper specialty clinic. I come to the end of my talk. One differential diagnostic sign to consider is also maybe the patients are on neuroleptics, for instance, in schizophrenia, neuroleptics or antipsychotics. It's always a very difficult choice if your patient becomes catatonic and has a schizophrenia. You never know. Maybe the symptoms are just due to the neuroleptics and what is called a neuroleptic malignant syndrome. Then you have the difficult choice of maybe reducing the neuroleptics. That will improve maybe the catatonia, but may deteriorate the underlying schizophrenia. This is always a walk on the tightrope. You might also want to try some other neuroleptic, like one of the modern atypical neuroleptics, for instance, clozapine, which have a lower likelihood of neuroleptic malignant syndrome. In summary, when you see a patient, strange postures, strange behavior, strange affect, and you cannot exactly locate that. Is it a mental disorder, like schizophrenia, depression, which may be covered or hidden, or is it a medical disorder, maybe the patient is in cancer treatment and develop a catatonic syndrome? Please be aware of the possibility that this might be a catatonic syndrome. This is important because either medical catatonia or psychiatric catatonia, you can treat very well in 60–80% with lorazepam or other fast-acting benzodiazepines. If your patient develops fever as part of the catatonia, please think about immediate electroconvulsive therapy. With that, I stop my talk. I want to hint that here we just brought out a recent book about catatonia, where we have the whole research, but also the clinical differential diagnosis and clinical procedures well described. And if you want to know more about our approach, also look at our website as below, or the recent book, Neurowaves. Thank you very much.